Good afternoon. My name is Ana Marija Šantić. I'm a neurologist and somnologist. I work at the Center for Sleep Disorders in Psychiatric Clinic Rapče here in Zagreb. Today I will tell you something about rapid eye movement sleep behavior disorder, which is, as the name says, a behavior disorder arising from REM sleep. The importance of REM behavior disorder in neurodegeneration is that it can precede the onset of neurodegenerative disorders, mainly synucleinopathies, by many years, such that it may be used as an effective early marker of neurodegenerative disorders, precisely synucleinopathies. REM behavior disorder is a sleep disorder characterized by enacting one's dreams during REM sleep, with most of the dreams being violent or aggressive, so that the patients often complained to hurt themselves or bad partners during these episodes. Most of these episodes appear later in the course of the night because of the natural REM predomination in second half and especially in the last third of the night. While postural tone is totally abolished during normal REM sleep, a condition named atonia, RBD is associated with impaired abolition of muscle tone during REM sleep, a condition called REM sleep without atonia, which enables the dream enactment. Dream mentation and behavior are often those of self-defense or defense of others against attacks by unfamiliar people or animals. Aggressive, action-filled dream mentation and violent behaviors are frequently reported in patients with RBD. Prevalence of RBD based on population is only up to 2%, but much higher in patients with neurodegenerative disorders, especially synucleinopathies. RBD occurs in 30 to 50% of patients with sporadic Parkinson's disease, preceding the onset of Parkinsonism by several years in about 20% of them. The majority of patients with multiple system atrophy have RBD, up to 88% according to researchers, as well as majority of patients with dementia with Lewy bodies. In fact, RBD is thought to be the essential feature in both of these disorders. Lesion or dysfunction in REM sleep and motor control circuitry in pontomedullary structures cause RBD phenomenology, and degeneration of these structures might explain the presence of RBD years before the onset of Parkinson's disease, dementia with Lewy bodies, or multiple system atrophy. Back in 1965, a famous researcher, Michel Jouvet, obtained a suppression of REM sleep atonia and established a cat model of RBD after a specific lesion of peri-alpha region of the locus coeruleus in dorsolateral part of pons. This picture shows the proposed pathophysiology of RBD. It shows very complex mechanism, and we can see that many brain structures are involved in this pathophysiological mechanism, especially nuclei in dorsolateral pons and ventral medulla oblongata. Most of pathological changes are found in sublateral dorsal nucleus in pons. The neuropathology of RBD is strongly linked to alpha-synucleinopathy with documented lesions within the sublateral dorsal nucleus. Sublateral dorsal nucleus projects to ventral reticular nucleus in medulla, which blocks spinal motor neurons, producing the atonia. Lesions within pontomedullary structures are responsible for loss of normally present atonia during REM sleep. Polysomnography with audio-visual recording is needed to confirm the diagnosis of RBD and exclude other conditions that may mimic this disorder. On polysomnography, RBD is presented as repeated episodes of vocalization or complex motor behaviors during REM sleep, which reflects the loss of normally present atonia in REM. That is, REM sleep without atonia. Sometimes, when typical behaviors are not seen in polysomnography, but are known to exist, based on previous medical history. Even the presence of REM sleep without atonia is sufficient to diagnose patients with RBD. In this picture, we see a screenshot of a 30-second epoch of polysomnographic recordings from a 70-year-old male patient. Polysomnography was done in Center for Sleep Disorders. The patient complained of hitting and kicking in bed while dreaming, with most of dreams being violent and health-threatening character. He also complained of anosmia, also lasting for a few years. But patient didn't exhibit any other clinical signs of movement neurodegenerative disorder. Here in recording, we can see heightened signal in chin EMG, or the loss of normally present atonia, which would present as flat line. While EEG is concordant with REM sleep, we can see rapid eye movements in electrooculagram. In video recording, there were no violent movements at the time. The patient only exhibited short-lasting stereotype movements of right hand. This is a case of idiopathic RBD, and in cases of idiopathic RBD, precisely those patients who at the time of diagnosis don't exhibit clinical signs of Parkinson's disease, DLB or MSA. The treatment is mainly symptomatic and is based on lowering motor activity in sleep, promoting sleep continuity, and readdressing sleep desynchronization. It is important to diagnose and treat any other sleep disorders common in that age, such as obstructive sleep apnea, because it may further promote parasomnias by mechanism of sleep fragmentation. Clonazepam and melatonin are main substances used in this treatment. In elderly, melatonin is almost always preferred because benzodiazepines can lead to falls and fractures and have negative side effects on cognition. In conclusion, I can say that while there is no known effective neuroprotective substance yet, it is important to recognize these parasomnias as they can precede typical motor and cognitive symptoms of neurodegenerative disorders by many years, and as such demand regular neurological and neuropsychological follow-up.